So I will just share my screen. Hopefully you all will be able to see the slides. All right. So initially, the title I was given for the talk was Breast Cancer Research from Laboratory Bench to Patient Bedside. But as she mentioned, I'm a breast cancer surgeon. And so I took the liberty of changing the title a bit to talk about breast surgery clinical trials, where we were, where we are, and where we are going. One of the issues that I was asked to talk about was breast cancer survival and how that's changed over the decades. And so I put here a timeline for you to kind of see how the survival rates have changed. So you can see the rate per 100,000 and the year along the x-axis. And I've mapped out some of the key advances that have happened that so that you can see how they map onto this timeline. Now, you'll notice that many of these are medical oncology advances in chemotherapy with the discovery of adriamycin and taxanes, the discovery of tamoxifen for endocrine therapy to treat estrogen receptor positive cancers, trastuzumab for HER2 positive cancers. We've seen the development of aromatase inhibitors in the mid-2000s. And then more recently, seeing things like pertuzumab and TDM1 even getting more targeted in terms of our therapies. You'll see also that I've put on mammography, which certainly has allowed us to discover cancers at an earlier stage when they are the most treatable. But there are no surgical advances here. So why is that? Well, we know that breast cancer surgery has two main objectives. The first is tumor extirpation to take the cancer out of the breast, and the second is lymph node evaluation. Now, these may not improve survival, but we've had a number of clinical trials that have occurred over the past several decades that have really improved how we do this and how we can contribute to the multidisciplinary team. And so I want to look at clinical trials that have really changed the landscape of breast cancer surgery. Now, back before the 1960s, patients who were diagnosed with breast cancer had a Halsted radical mastectomy. There was really no choice involved. And this involved removing the breast, the pectoral muscles, all of the lymph nodes. And you can see here a patient who has had a Halsted radical mastectomy. You can see the ribs here. And this is really a disfiguring cosmetic outcome. Very often these patients had lymphedema of the arm because all of the lymph nodes were removed. Now, in the 1960s, there was a landmark clinical trial that occurred, and this was the Nsa Bp B18 Trial, which randomized patients to either having a Halsted radical mastectomy versus having a total mastectomy. And the difference there is that in a total mastectomy, the lymph nodes are not removed, and neither are the pectoral muscles. Now, they did have a group with positive nodes who also had radiation therapy. So here you can see that survival, whether you had positive nodes or negative nodes, now clearly if you had negative nodes, you did better than positive nodes, but in both of these groups, survival rates were equal. And in fact, the distant recurrence rates, the local recurrence rates, if you had positive lymph nodes, again, were similar regardless of the surgery that you had. And similarly, for negative nodes, although in local regional recurrence, there was a difference. And so because of that trial, we were then able to move towards offering patients a simple mastectomy. So here's a patient who has had a simple mastectomy. The pectoral muscle was not removed, the lymph nodes were not removed, and you can see that while she is still flat-chested, the cosmetic result is much better. But what happened after that? Well, we've now gotten to the point where we're able to offer patients what's called a skin-sparing mastectomy with immediate reconstruction. So here you can see a patient who has had that procedure. She's had bilateral mastectomies and reconstruction. The skin pocket was preserved, and she simply had tissue moved from another part of her body into the breast pocket to recreate the breast. Now, this happened without clinical trials. Rather, there were a number of large cohort studies that looked at the differences between conventional mastectomy, as shown on the top picture, and skin-sparing mastectomy, as shown on the bottom picture. And you can see over a number of studies that I've shown here with fairly long follow-up that the local regional recurrence rates between these two operations was the same. And so we were able to offer our patients a more cosmetically acceptable option. Now, through the 1960s and into the early 1970s, there was another landmark clinical trial, and this was the Nsa Bp B18 trial. This trial was remarkable because it randomized patients to either having a total mastectomy or a lumpectomy with and without radiation therapy. And what you see is that the survival rates were the same, and the local recurrence rates were better if you offered patients radiation. And so we were able to offer patients a partial mastectomy. This is a patient who has had a partial mastectomy, and I would say that it will be pretty difficult for you to even suggest which side she had her cancer on. She actually had it here. The incision is hidden along the areolar border. But here she is with her own natural breast and cancer-free. Now, we know that in removing these cancers and retaining the rest of the breast, we need to ensure that we get clear margins. Because if we have cancer close to the edge of the resection specimen, or what's called a positive margin, we know that that's associated with a twofold increase in local regional recurrence. So I was also asked to talk about some of my own work, and this is really where we've had the most impact recently. There were a number of surgeons who did this procedure differently. So normally now we find these cancers, often they're not palpable, so we have wire localization to show us where the cancer is. And then we remove the specimen and we take an x-ray right in the operating room. That's where this was taken. And for many surgeons, what we used to do is we would look at this and we would say, gee, this cancer seems to be close to this edge. I'll take more here. There's no need to take more over here since the cancer appears to be quite far from that spot. Despite our best efforts, however, 20 to 40% of patients would have a positive microscopic margin once the pathologist looked at the specimen under the microscope, leading some to argue that maybe we should take more tissue all the way around. Now, for a long time, there were great debates over this. Surgeons like me, who were selective cavity shave margin people who would only take some here, would say, why should we take more all the way around? This seems to be just taking more tissue. Others would say there are plenty of retrospective studies where we've looked at surgeons who take more all the way around and surgeons who don't, and have found that those who take more all the way around do better. But this really required us to look at this in a randomized controlled trial. Why? Because retrospectively, you couldn't really address the issue of whether surgeons had different abilities. You couldn't address the issue of other factors that may be taking place. For example, how did this affect volume of tissue removed? How did this affect cosmetic outcome? How did this affect cost? And so on. And so we designed a randomized controlled trial where we took stage 0 to 3 breast cancer patients who were to undergo a partial mastectomy. Surgeons were allowed to do a partial shave resection as they felt necessary. So here I would have taken a little bit more here until I was happy and ready to close. So at this point, normally I would have stopped the operation. And so we took a number of surgeons at Yale, all of whom did this procedure exactly the same way that I did. And at that point, we said to them, now stop. We intraoperatively randomized them either to no shave, that is to say, you were happy with the operation that you did, so simply close, or take a little bit more tissue all the way around, shave. What we found in this single center randomized controlled trial, which was subsequently published in the New England Journal, was that there was a dramatic reduction, almost 50%, by taking cavity shave margins. The question then was, is this replicable in other centers around the country and around the world? We then did a multi-center randomized controlled trial, which found exactly the same thing, and this has now been replicated by others as well. Now, I'm not going to spend too long talking about medical oncology advances, but I will mention this clinical trial, which I think is really a landmark one, which is the Nsa Bp B18 trial. What this trial did is it answered the question of, should we do chemotherapy before or after surgical resection? As I mentioned, breast cancer management is really a team sport. And for some, they felt that offering patients a surgery first would get the tumor out of the patient, perhaps improving survival. And then we could treat whatever was left over with chemotherapy. For a long time, this was kind of standard. Others, however, argued that the main risk of death from breast cancer comes from metastases. And therefore, if we offer patients chemotherapy up front, maybe we can reduce the death rate and use surgery to simply remove whatever was left over. So the Nsa Bp randomized patients into these two arms, either having surgery first followed by chemotherapy, or the same chemotherapy regimen followed by surgery. What they found was that there was no difference in disease-free or overall survival. But what they did find was that we were able to take patients who presented with cancers like this and turn them into cancers that you can barely see. The clinical complete response rate for the patients who had chemotherapy first was 36%. The clinical partial response rate was 43%, and the pathologic complete response rate was 13%. The other thing we found was that the pathologic complete response rate correlated with survival. It's not to say that you wouldn't survive just as long if you had the surgery first. Remember, there was no difference in survival rates. It's just that having this information, we could predict, we could tell patients that they would do better if they had a pathologic complete response rate. And that was really key because that led to the FDA using the pathologic complete response rate as a surrogate in clinical trials, which have really assisted in terms of drug development. The other thing that happened that was interesting from the surgical standpoint is that we could increase breast conservation rates. We could take patients who would not be candidates for a lumpectomy or breast conservation and whose only option was a mastectomy and turn them into patients who could have breast conserving surgery. We also found that there was a reduction in the positive axillary lymph node rate, which will become important in a minute when we talk about lymph node surgery. So that's where we are now. Where are we going? Well, now we're beginning to push the envelope of whether we even need surgery. So there are a number of clinical trials looking at low-risk Dcis, which is a pre-invasive lesion. And here you can see the 3 trials listed with their inclusion criteria. So certainly these are all low-risk patients, and really seeing whether we can randomize them to surgery versus active surveillance. The idea being maybe some patients who are diagnosed with low-risk Dcis may not need surgery. And this goes to the concept that maybe we, through our screening efforts, are finding patients who are being diagnosed with low-risk Dcis whose diagnosis would never harm them to begin with. But we're also looking at the other end of the spectrum, triple-negative breast cancers or HER2-positive breast cancers. Now, many of you may know that triple-negative breast cancers are often what are thought of as very aggressive cancers. And so how is it possible that we can be contemplating not needing surgery for these patients? Well, the idea is that the advances in chemotherapy have been so great in these 2 groups of patients that we're beginning to see higher and higher pathologic complete response rates. Remember, pathologic complete response rate means that at the time of surgery, when you take out that specimen and give it to the pathologist, they don't see any viable cancer cells left. And so what this trial is doing is looking at these patients and treating them with neoadjuvant therapy, and we talked about that in the Nsa Bp B18 trial, and then doing some image-guided biopsies. If it looks like they have a complete response, and have no residual disease, they will be treated with radiation therapy alone. If they have residual disease, then they will have surgery plus radiation therapy, and we're going to follow these patients to see whether the patients who have no residual disease on these biopsies may be treated with radiation therapy alone. Now, I mentioned that the other aspect of breast cancer surgery, aside from tumor extirpation, which we've talked about, is lymph node evaluation. And remember back to the Halsted mastectomy, the way that we evaluated lymph nodes back in the day was with a complete axillary node dissection. Now, lymph node evaluation is really geared around 2 main purposes. The first is staging. Remember that whether your lymph nodes are involved or not makes a big difference in terms of your stage and therefore subsequent treatment. The other is for local control. Clearly, if the lymph nodes have cancer, you don't want to leave that cancer in the patient. Well, in the late 1990s, a technique was developed for breast cancer called sentinel lymph node biopsy. Now, this had been used in a number of other malignancies prior, but it was really tested in the late 1990s, and the way that this works is as follows. We can inject a radioactive tracer plus or minus a blue dye into the breast. And initially, we did this around the tumor. We now know that we can do this around the nipple areolar complex. But essentially, it tracks through these lymphatics to identify the first draining lymph nodes, or these sentinel nodes. We can identify these in the operating room using a gamma probe if we used a radioactive tracer, or by simply looking for these blue lymphatic channels and these blue nodes in the operating room. Then we can remove just these nodes and send them to pathology, who can look at them by frozen section intraoperatively and tell us whether they see cancer there or not. And so the idea was, is this accurate? And can we really identify these sentinel lymph nodes? And then if we complete the axillary node dissection, does the sentinel node reflect the rest of the axillary basin? Well, a number of studies, which were all cohort studies, looked at that question, and you can see that these demonstrated very high accuracy and identification rates and reasonable false negative rates. And so sentinel lymph node biopsy really became the mainstay. It was after this had become fairly commonly used, however, that Cragg and colleagues published the findings of the Nsa Bp B18 trial, which essentially sealed the deal on sentinel lymph node biopsy as part of the surgeon's armamentarium. What this did was it took patients, it had surgeons do a sentinel lymph node biopsy, and then patients were randomized either to a routine axillary node dissection, essentially doing an axillary lymph node dissection on everyone, versus only doing that axillary lymph node dissection if the patient was sentinel lymph node positive. What happened? Well, not unexpectedly, the survival rates were the same. Now, this should not be a surprise to any of you. We knew back from the Nsa Bp B04 trial that the survival rates would be identical because there was no difference, remember, between the radical mastectomy and the total mastectomy. What you also found, however, was that the local recurrence rate was very low in both groups. Then we started asking, well, do we really need to do the axillary lymph node dissection on everybody? These are a number of studies that were done, all cohort studies, looking at a number of patients. You can see here, ours was one of the largest studies looking at the Louisville Sentinel node group, where we found that in 63.1% of patients, the sentinel node was the only node that had cancer in it. So going on to do an axillary lymph node dissection for these patients would have been unnecessary in 63.1% of patients. You've already staged the patient and you've already removed those sentinel nodes that had disease. The other lymph nodes had no other disease. And this led us to create models to predict which patients had non-sentinel node metastases and which patients could potentially obviate the need for an axillary node dissection. All of that became rather obsolete with several clinical trials, all of which had essentially the same format, which said, what about if we didn't even apply a model? We just took sentinel lymph node positive patients and we either randomized them to axillary node dissection if they were positive, or observation or radiation therapy. The Z11 trial was a non-inferiority study which had a target accrual of 1,900. You can see that it did not meet its target accrual. And what it found was that in the group who had an axillary lymph node dissection, 27.3% had non-sentinel node metastases. So remember, this is echoing back to the findings that we had previously, where the majority of patients do not have any further lymph node metastases. Again, not surprisingly, survival rates were identical. And here's the real kicker, is that the lymph node recurrence rate was essentially very low in both groups, with a median follow-up of 6.3 years. And so in patients who meet the criteria for the Z11 trial, which is people having partial mastectomies where they will get whole breast radiation therapy, because all of these patients had whole breast radiation therapy, which again targets part of the axilla, that they would not require an axillary lymph node dissection. The IBCSG 2301, again, a similar trial, slightly different inclusion criteria, but essentially very similar findings. They did not meet target accrual. Very few patients had non-sentinel node metastases. Survival rates were equal in both groups. Lymph node recurrence was very low. Then we started asking the question, well, does sentinel node biopsy work after neoadjuvant chemotherapy? Remember, we had now been starting to do a lot more lymph node, neoadjuvant chemotherapy, but all of the studies with sentinel lymph node biopsy had been done in the setting of naive patients. That is to say, people who had not had chemotherapy already. And so the Z11 trial randomized node-positive patients who got chemotherapy and looked at those who had residual nodal disease. And what they found was that we could identify the sentinel node after chemotherapy in 92.5% of patients, that it was accurate in 91.2% of patients. And so the false negative rate, those who were sentinel node negative, but axillary lymph node positive, had a false negative rate here of 14.7%. So where are we going? Well, now we're trying to see, now that we know that we can do sentinel node biopsy after neoadjuvant chemotherapy, well, and we know that it's accurate, can we now avoid an axillary node dissection in those patients? Very similar to how we avoid an axillary node dissection in some patients who are sentinel node positive, regardless, a la the Z11 trial. And so this is the Alliance 11202 trial, which is currently accruing, which will help us to answer that question. So in summary, I've given you kind of a whirlwind tour through breast cancer surgery clinical trials. Where we were really in the era where there were no choices. Everybody had a Halsted radical mastectomy. Today, we have options for women, right? We can offer reconstruction. We can offer breast conserving surgery. We can do sentinel node biopsy for axillary staging and don't necessarily need to complete an axillary node dissection. And where we're going is really less surgery, capitalizing on a multidisciplinary approach, using more targeted therapy, often with neoadjuvant therapy, and increased use of radiation. And of course, critical to all of these developments as clinical trials. So with that, I will thank you and send you greetings from Yale. And I would be happy to answer questions in the panel.